I'm Professor of Biostatistics at Barts and London Medical College, but my main role over the past 24 years that I've been there has been working with general practitioners in the Department of Primary Care and mostly on trials, and a large part of that's been on cluster randomised trials, and that's my expertise. I think the main reason is the kind of interventions that people want to do in primary care. So in secondary care, we're often looking at drugs, surgery, different kinds of treatments for individuals, but actually in primary care what we're often trying to do is to change the behaviour of practices, of the practitioners within the practices, of patients, or change the organisation, the way appointment systems work, something like that. So those kind of interventions lend themselves naturally to cluster randomised trials. The things that most people know about cluster randomised trials, but it's still worth emphasising, is that you need to get your sample size and your analysis right. Sample size is particularly important because in any trial, if you don't get your sample size right, then you haven't got enough power to show what you need to show. So for cluster randomised trials, your sample size normally needs to be larger than it does in an individually randomised trial. And then once you get to the end of your trial, you need to do the analysis properly, and for that you usually need a statistician. So those are the two sort of basic things, but I think over the past 10, 20 years, people have become much more aware that one of the major issues with cluster randomised trials is that there are biases that can occur in cluster randomised trials which don't occur in individually randomised trials. And the classic sort of serious bias is something that I like to call bias due to identification or recruitment, because it happens when you identify and recruit patients in a certain way. So if you look at a cluster randomised trial, you have to randomise clusters. That's usually general practices in primary care, but actually you're taking your measurements on the patients, and so you actually usually need some consent from the patients as well to do that. And if you recruit your patients after you've randomised, then very often what happens is that there's some differential recruitment in your intervention and control group, because the intervention clusters have been randomised to the intervention. They know they're in the intervention group. They might even have had the intervention delivered, and so they recruit participants in a different way. And therefore you get this problem that you don't have the same number or the same kind of participants in both groups, and therefore you're not making a fair comparison. There is another issue with bias in terms of assessment, and this is not just with cluster randomised trials, but it's any trial where there's a potential that the outcome assessor might actually know which intervention group somebody was in. So any trial where your intervention is something that can't be blinded from assessors in a very easy way. So there are ways of dealing with that, but it sometimes takes a little bit of thought to make sure that your assessors are as blinded as possible, because otherwise you may get bias in the way they assess things. There are plenty of books now. If they're doing the trial in primary care, I would recommend the book that Sally Kerry and I wrote in 2012. I think because that has got a lot of examples from primary care. It's really focused in primary care, although it says it's about health services research. There are a good number of statisticians now in most universities who know about cluster randomised trials. In most universities they will probably be based in a clinical trials unit, and so I would say to somebody, get in touch with your local clinical trials unit, get the expertise from there. There are numerous papers that it's useful to read, but I think actually having a person on board who can guide you is probably the most sensible thing. So what I'm going to do is look through the sort of history of cluster randomised trials right from the beginning, really, and the contribution that primary care has made to that, both in terms of numbers and types of trial, but also in terms of the methodology, because actually I think it has had a significant contribution. A lot of cluster randomised trials are done in primary care, and a lot of methodologists have worked in the primary care arena and produced a lot of methodology as a result of that. And then at the end, I'm going to have a few perhaps slightly wacky reflections on where we might be going as a result of where we've come from. So it's basically around trials in cluster randomised trials in primary care, but with that sort of stance.
Okay, but first a message from our sponsors, which is very important. This is a sponsored session. So the HRB Primary Care Trial Network Ireland aims to improve individual patient health and healthcare by conducting high-quality, internationally recognised randomised trials in Irish primary care. And if any of you want to get involved, Breda will get you and catch you at the door, and you can sign up. The network was established in 2015 with 2.5 million funding over 5 years by the Health Research Board. It's a collaboration between NUIG, RCSI, Queen's, and the ICGP, and other key partners are AUDGPI and, of course, primary healthcare professionals. Okay, so that is? Perfect. Okay, now Sandra. So she's a professor of biostats at Barts and the London School of Medicine and Dentistry, and she's been joint lead of the Centre for Primary Care and Public Health since 2007. She's had a varied career, including teaching maths in schools in Nigeria and the UK, and she started work in primary care in 1996 and completed a PhD, it says here, unusually late in her career in 2005. So all of you can do your PhDs unusually late. And her research interests are cluster randomized controlled trials and complex interventions, and has loads of publications in the area. So let me hand over. Thanks.
Thank you.
Thanks, Sandra.
Thank you. So just a little rider to that. I am no longer head of department. Sorry, I didn't look carefully enough at your notes. I am no longer head of department, but I was for 10 years head of department of the Centre for Primary Care and Public Health, together with the GP. We did it jointly. So this building on the slide is where I work in London, and I'm going to talk about cluster randomised trials in primary care. Where have we come from, and where are we going to? I'm going to talk a little bit to start off with about what cluster randomised trials are, just in case anybody is not really familiar with them. And then I'm going to talk about where we've come from, giving a kind of brief overview, but also some personal stuff in there about the trials that I've been involved in, but also the contribution of primary care, I think, to the methodology of these trials, which has not been insignificant. And then at the end, a few reflections on where we're going. So what is a cluster randomised trial? Basically, for those people who are not aware, in a cluster randomised trial, we randomise clusters or groups of individuals instead of individuals themselves. So that sounds quite simple. The clusters can be clinics, hospitals, general practices, schools, villages. Most of the trials that I've been involved in have been randomising general practices. And we randomise those groups or clusters to the intervention and control group, in contrast to an individually randomised trial where we're randomising individuals. So there are implications of this design, and basically the implications come from the fact that usually those within a cluster are more alike in some way than those in different clusters. So what we're particularly talking about here is whether people are more alike in terms of our outcomes, in terms of what we're measuring. So if we take a primary outcome for our trial and we look across our clusters, the likelihood is that within one cluster, people will be more alike in relation to that primary outcome than people from the whole population. And that we usually refer to as clustering, and the extent of that correlation within a cluster is measured by the intra-cluster correlation coefficient. So, for example, if you have clusters where everybody within a cluster has exactly the same measure for the primary outcome, obviously not a very likely scenario, then your intra-cluster correlation coefficient would be 1. If you have a situation where people aren't more alike at all within a cluster than across the whole population, then your intra-cluster correlation coefficient will be 0. For most trials in primary care, the intra-cluster correlation coefficient is something around about 0.05. So it measures the extent of the correlation within a cluster, or another way of thinking about this is that it measures the difference between clusters. And one of, or two of the implications of that, and I would say these are the main implications of clustering. So two implications of that are firstly that we need to account for the clustering in the sample size, and generally what that means is you need larger sample sizes for cluster randomised trials than you do for individually randomised trials. And I've put a little formula up there which if you've ever done a cluster randomised trial, you may have seen that somewhere. That's what you have to multiply your sample size by if you're doing an individually randomised trial to estimate how many people you need in your cluster randomised trial. It's quite simple. It depends on two things: the intracluster correlation coefficient, which I've just been talking about, and that M there is the number of individuals in each cluster. Now you'll notice that formula assumes that you've got the same number of individuals within each cluster. In general practice, when we're doing trials with general practice as clusters, that's not usually the case, and I'll come back to that. But it's relatively simple to estimate how many you need in a cluster randomised trial compared to an individually randomised trial. And the second thing is that you need to account correctly for clustering in the analysis. I'm not going to say any more about that, except that if you're analysing a cluster randomised trial, you should probably talk to a statistician who will know how to do that. So these types of trials are particularly common in primary care, and the reason is because of the types of intervention that we're evaluating. So I'm going to give you some examples of that, of trials that I've been involved in, either as part of the trial team or as part of the steering committee. So very often trials are targeted at professionals, and one example is a trial that we published in 1999 where we were looking at secondary prevention of coronary heart disease. And what we wanted to do was to try and make sure that GPs were doing something for their patients who'd come into hospital and had an MI. What were they doing for their patients afterwards? So the intervention was very simple. It was prompts to GPs to do something about their patients who'd had an MI. And we used a cluster randomised trial because obviously if we were prompting GPs about some of their patients, that they should do something particular with some of their patients, then the idea that they should do that for other patients would be in their head when they saw other patients who'd had a myocardial infarction. So it would have been very difficult to randomise within a practice. So we randomised practices. Either you were in a practice where you were going to get these prompts, or you were in a practice where you were not going to get these prompts. Another example of the type of intervention that you might do in primary care is where you're changing organisation. John Campbell in Exeter ran a very nice trial where he was looking at GP and nurse triage. So it's changing the appointment system to have GP and nurse triage, or kind of usual appointment systems within primary care for people who wanted to have an appointment. And that was quite a simple cluster randomised trial with 3 arms and a relatively a complicated trial to do, but a relatively simple intervention. And again, that was aimed at changing the organisation. So it would not have been possible to randomise individuals in this trial. There are other trials where you're not necessarily changing the organisation, but you might, for example, be trying to change the culture. So we did a trial in nursing homes where we were trying to look at whether increased activity of older people in nursing homes would affect depression, positively actually reduce depression, obviously. And in that trial, what we were doing was a whole lot of things within the homes to try and increase activity. So we had physiotherapists giving the older people individual assessments. We had exercise classes. We had training for the staff within the nursing home. And then we had team members continually trying to reinforce that intervention. The idea that the whole people's activity within the home. So again, it would have been impossible to do that kind of trial at an individual level. You can't individually randomise people to that. Finally, it may be logistically or financially easier to do a cluster randomised trial than an individually randomised trial. And so, for example, we did a trial with asthma liaison nurses where the intervention was putting an asthma liaison nurse into a practice. Now, we could have put asthma liaison nurses into all the practices and randomised patients to either see an asthma liaison nurse or not see an asthma liaison nurse. But actually, it was a lot easier to put asthma liaison nurses in only half the practices and not in the other practices. And so we did a cluster randomised trial in that case. So that's a quick whip through, and I'm going to come back to a couple of those cluster randomised trials later on. So where have we come from in terms of doing cluster randomised trials? So this is a very brief history. I would not be being fair if I didn't include in a brief history this guy on the left, Everett Franklin Lindquist, who first raised the whole kind of issues, the statistical issues around clustering in the field of education. Because in education, you've got children within classes, you've got classes in schools, so you've got clustering there. And he raised that in the 1940s. But the guy who really started doing cluster randomised trials in healthcare was G.W. Comstock in Alaska in the 1950s, did a number of trials around tuberculosis. And so the early cluster randomised trials were really in infectious diseases. And the reason why people did cluster randomised trials in that case was because if you randomise individuals, then if you've got an infectious disease and you've got a population where you're randomising some people to get some kind of a treatment, then that naturally is going to spill over to other people that they're in contact with, who may also be less likely to get whatever it is, the infectious disease that you're looking at. So doing an individually randomised trial, you get this contamination. The effects of the intervention that you're giving to some people will spill over and also have an effect on your control group. So there are a few cluster randomised trials in the sort of mid-20th century. And then in 1977, at the National Society for Epidemiological Research meeting, there was a symposium on coronary heart disease. And during that symposium, the whole issue of clustering arose again. And this guy called Cornfield is commonly identified, at least within the statistical community, as the guy who then really started off the whole kind of cluster randomised trial movement. And in this little quote here, particularly the underlined bit, he was emphasising what I said at the beginning, that if you do a cluster randomised trial, you have got to make sure that you do your analysis correctly. It has got to take account of the fact that that's what you've done. You can't treat it like an individually randomised trial. So then what happened? This slide shows the number of trials, well, the number of studies with cluster randomy, so that's cluster randomised with a S or randomised with a Z in the title over the period since the mid-20th century up until 2016. So this is a very quick and dirty search. So some of those papers will be methodological papers, they won't be trials, or there might be something that's got that word in the title for some other reason. And also, I know, because I was involved in a trial like this, that won't capture all cluster randomised trials, because particularly when these things started off in the 1990s, then a lot of the trials were done without putting cluster randomised in the title at all. So this is not a definitive graph, but it gives you an idea of the interest in this area, and I do think that most of the papers will be looking at the reports of a cluster randomised trial. So you can see there that in the 1990s you've got a few trials, and then they really take off at the beginning of this century, but then in the 7 years between 2010 and 2016, you've got nearly 3,000 trials. And just in case you think that sort of increase has slowed down, it hasn't. So we've got an almost a tripling of the number of trials between 2011 and 2016. And again, using very quick and dirty methods, which I won't go into, I estimated that at least 840 of these trials have been done in primary care. About a quarter of cluster randomised trials are done in primary care. So I'm going to talk about a few of those trials now. The first one I'm going to talk about is the Southern Ontario randomised trial. I don't know what you think of when you think of Southern Ontario, but when I Googled, these were the kind of pictures I got. So this is what Southern Ontario is famous for, but actually it's famous for another reason. The first cluster randomised trial in primary care, unless there's somebody here who's going to disagree with me and say they know an earlier one. This is actually interestingly published before Cornfield's famous statement in his paper in 1978. And bizarrely, I think, because I thought this is a fairly recent concept, it's training nurses to become nurse practitioners. And it was done in 14 family medical practices, and there's a number of outcomes. I've underlined one there because that's the outcome where you would have to actually do something, measure something on patients. So your patients are involved as well, and so you may have that kind of clustering effect that you've got to take account of. Now, a quick look through the paper, I could find no sample size calculation whatsoever, and I couldn't really understand what they'd done with the analysis, so they had some nice fancy graphs of the results. So in terms of what I said at the beginning about making sure that your sample size and your analysis take account of clustering, this one wouldn't score very highly, but I think it scores quite highly out of interest that they were doing this back in 1973. So the wonderful thing about acronyms for trials, which everybody has got now, is that you can play with your acronyms a bit. So these two acronyms, POST and OPERA, were for the two trials that I've already mentioned. The first one, postal prompts to GPs to see if we could do something about secondary prevention of myocardial infarction, and the second one, the OPERA trial, was the older people's exercise intervention in residential and nursing homes to see if we could reduce depression. So much more sophisticated approach to developing an acronym in the second rather than the first. And there were differences between these two trials. There's 14 years between the publication of these two trials, so I'm going to just outline some of the differences. One of the differences is that the intervention in the second one, and I've already described that to you, was multifaceted, much more complicated. So we've got a much more complicated intervention, but there were other differences. So the post trial, the myocardial infarction trial, was done just in East London. And basically there were 4 of us and we did everything. You might recognise a couple of people there apart from me. It was quick, relatively quick and cheap. When you look at the price, it looks absolutely amazing. It was 4 years from awards to publication of the paper. We look at the OPERA trial. It was slower. It wasn't that slow, but it was slower, and it was 10 times more expensive. In addition, now I can't say really it was international. I've just put that in because it kind of looked nice. But it was national. It wasn't just in the East End of London. A cast of thousands, not quite thousands, but there were a lot of people involved. And why am I saying that, apart from the fact that it's the acronyms are nice to play with? I think this has issues, particularly for cluster randomised trials. We've got here a longer trial, a more complicated trial, a trial with far more people involved. When there were just 4 of us involved in post, it was very easy for everybody to understand the issues in cluster randomised trials, because I'm going to come on and talk about some more issues. Once we got more people involved and the trial went on for longer, there were always people who weren't really quite even sure what a cluster randomised trial was, or why it was different from other trials, and that can land you in some issues which I will talk about later. So I think this issue that having much bigger, much more complicated, much more longer lasting trials, if it's got a complex design like a cluster randomised trial, can be an issue. But let's talk about the methodology, because I think primary care, I don't want to over-egg this, but I will over-egg this because I'm in a primary care meeting. Primary care, I think, has had a very significant contribution to some of the methodology here. Now, I've sort of divided this into three, the brief history of methodology, and I would be very remiss if I didn't mention, in talking about methodology, the guy on the left, Alan Donner. He is, will forever be, the leader in methodology in cluster randomised trials. And if you look before about 1990, any methodological papers will be authored or co-authored by Alan Donner. In the middle there, though, and I don't know, there probably will be some people here who remember this. I've put Martin Bland and Sally Kerry, because in that middle era, around the turn of the century was a time when methodologists, and if you don't know them, both Martin and Sally are statisticians, started to really put the ideas about cluster randomised trials out into the mainstream. So in the BMJ, in the British Journal of General Practice, and in Family Practice, they wrote papers explaining what cluster randomised trials are. And they're also a collection of two books and an HTA monograph, which also talked about the issues in cluster randomised trials. So that's the second period, I think, around the turn of the century. And then you get this third period where you get a whole load of people involved in cluster randomised trials, not only methodologists, but practitioners as well, including Andrew Murphy, who wrote a paper, I think it's in the European Journal of General Practice in 2006, about the issues in cluster randomised trials. So you get a lot more people interested in some of the issues, and three more books. So the one on the left is just called Cluster Randomised Trials, I think, but it's basically looking at trials in low-income countries. The middle one is a book that I wrote with Sally Kerry, and we titled that A Practical Guide to Cluster Randomised Trials in Health Services Research. But since we both have worked in primary care for most of the time that we have been working in health, then health research, then it really is a book about trials in primary care. It's got loads of examples in it. And then the one on the right was written by Mike Campbell. So there's the two Campbells here, Marianne Campbell and Mike Campbell, both statisticians, both interested in cluster randomised trials, both have worked in primary care. And the one on the right is written by Mike Campbell and Stephen Walters, and that's a lot about the analysis of these trials. So with this sort of increase in the number of trials and this increased involvement of people within the methodology, what has been the result of that? So this slide shows a number of reviews, the results of a number of reviews of cluster randomised trials, 14 reviews, and the blue bars show you the proportion of trials within the review that correctly accounted for clustering in the sample size, and the green bars show you the proportion of trials in the review that correctly accounted for analysis. And what I've done here is to split the reviews up according to whether most of the trials were published in the 20th century or most of the trials in the review were published in the 21st century. And what you can see there is an immediate sort of change. The little bars by the side indicate the averages. So the average number of trials that have counted correctly for analysis has gone up a bit, from 50-something to about 70. The number of trials correctly accounting for clustering in the sample size has increased by quite a bit. So there has been quite a significant change in the quality of these trials, and in that third period, we also had the consort extension for cluster randomised trials published. Marianne Campbell was the first author of that, and that, I think, also has contributed to this improvement in methodology. But primary care has had quite a significant contribution. So one of the things about doing trials in primary care is we usually got general practices as clusters. And I sort of alluded to earlier on, as you know, general practices aren't all the same size. So if you're doing a trial in primary care, it's very often that you get variable cluster size. If you're recruiting people with diabetes in a small practice, you've got a small number. In a large practice, you've got a large number. And that led to work looking at how do you calculate a sample size if you've got variable cluster size. Also, the other thing that we're often doing in primary care is to recruit individual participants after we've randomised. So we randomise practices, and if you're looking at something like a back pain or acute respiratory infections or something like that, then it's when people come into the practice that they might get recruited into your trial. That causes particular issues in cluster randomised trials, which I'm going to talk about in a moment, and some of that work has been done drawing on primary care. And I think the other issue which I also described at the beginning is in a lot of these trials we are aiming interventions at practitioners. One of the issues there is that are these practitioners then, the people we are aiming our intervention at, are they participants in our trial? And there's a nice piece of work done within the Ottawa Statement on the ethics of cluster randomised trial around that whole issue. So these are 3 papers. The first one, Sally Kerry and me and a few other people looked at this issue of sample size for cluster randomised trials where you've got variable cluster size. In the middle, this is the classic paper about what can happen in trials where you randomise your clusters first and then you recruit patients. And the third one is the Ottawa Statement published in 2012 on the ethics of cluster randomised trials. So I don't know whether you can see the numbers in this slide, but this is a slide showing along the bottom, it's got of each graph. So these are 6 different trials. Along the bottom of each graph, you've got cluster size, and then along the y-axis, you've got the proportion of clusters within that trial that had clusters of that size. So what you can see from the graph immediately is you've got very variable cluster size in most of these trials. What you may not be able to see is the little numbers there that say CV equals something. That is a measure of how variable the cluster size is. And if you look at those figures, they aren't actually very different from each other. This is for UK, randomising UK general practices, and generally speaking, that CV, that measure of how variable your cluster size is, comes out at about 0.6. So Sally and I and others did some work around this, and we developed a very simple, which I didn't put on the slide for some reason, and I apologise for that, but it's in our paper, a very simple extension of that formula I showed you right at the beginning for the sample size for cluster randomised trials. We developed an adaptation to that will cope with the fact that usually you haven't got fixed cluster sizes, you've got variable cluster sizes. Recruitment and randomisation. So in an individually randomised trial, what we normally do is we recruit a patient and then we consent them, we randomise them. It's one sort of process that we do with our individual patient. That's in an individually randomised trial. In a cluster randomised trial, everything gets separated. And it's one of the issues about cluster randomised trial, which I think is really important for people to understand, but it's quite difficult sometimes to explain. So in a cluster randomised trial, we've got a cluster. Somehow we've got to get the cluster to consent to be in the trial. That's usually through an individual within the cluster who's got some kind of authority to do that. Then we randomise the clusters. So a participant, can they consent to randomisation? The answer is no. That decision about randomisation is made at the cluster level. So the participant doesn't have an opportunity to consent to randomisation or not. What they could do is they could give their consent to data collection or to participation in some aspects of the trial, but they cannot give their consent to randomisation. Now the problem is that if you do the processes, the 3 processes in this order, then there's a high chance that you may get bias. And the classic study, as I mentioned from the previous slide, is the UK BEAM study. So first author Amanda Farrin. Unfortunately, this was a pilot study, so they were able to do some changes after they'd done the pilot. But this is the first study that really highlighted this major issue of possible bias. This was a study looking at back pain, and so they were recruiting participants in general practices when they turned up and had back pain. What they found was that they had even numbers of practices in the intervention and control groups. So what they found was in the control group only recruited 66 patients, whereas in the intervention group, they recruited nearly 3 times as many patients. And their conclusion from doing this was actually what happened was in the intervention practices, the offer of exercise classes or physiotherapy, which was their intervention, was so attractive, the GPs felt that they could do something for their patients, or the patients were attracted by this, that they were able to recruit a lot more patients, but also that the GPs were kind of looking out more for patients. And so maybe somebody comes in with another complaint and, what about your back pain that I saw you about last time? And they would recruit them into the trial, whereas that didn't happen in the control group because the control group didn't have anything particular to offer the patients. So this trial highlighted this issue of bias. What can you do about it? The best thing to do, if you can do it, is to do your participant consent to data collection and participation before you randomise, and then you don't have that issue. You've recruited your patients already, they don't know which group they're going to be in, the clusters, the general practitioners or whoever it is that you're dealing with, they don't know whether they're going to be in the intervention or control group. So there's no differential recruitment in your intervention and control groups. The problem with that suggestion is that very often it can't be done. Very often you've got a trial where you have got to, for some reason, recruit your participants after you have done your cluster randomisation. So there are a series of papers in the BMJ. The first one the first author is Puffer, published in 2003, which highlighted this issue. And then we wrote, again in 2008, highlighting this issue, but also other issues of bias in cluster randomised trials, because there are other issues of bias, which I haven't really got time to go into today in detail. And I'm just dealing with this one because it's the main one. Now, after we'd written the second paper, I went to a local SAPC conference in the UK, and somebody who I know very well works in my department. She said, I described what we'd said in this paper about the bias and, that you shouldn't have bias in your trial, and she said to me, the trouble is, you're always telling us what we get wrong. Why can't you tell us how we should do it right? So as a result of that, we published the third paper in the BMJ in 2009, and in there are some ideas about how to recruit participants if you have to recruit your participants after randomisation. So her name was Sally Hull. Some of you may know her. I just acknowledge her because actually that paper was her idea, really, not ours. So more recently, in this whole idea of this area of that particular bias in cluster randomised trials, I've been working with a group looking at the Cochrane risk of bias, that's what ROB stands for, risk of bias tool. And they are revamping the whole of the risk of bias tool within the Cochrane collaboration, but we've got a particular document now which is on the risk of bias purely for cluster randomised trials. There are 5 domains in the main tool, which you can see from this slide, that actually within our tool we have divided that first domain, domain 1, into 2 domains because we wanted a specific domain within the risk of bias tool that people would look at when they're assessing bias to assess this particular issue of identification and recruitment bias. There are a number of other things that we have looked at while developing this tool specifically for cluster randomised trials. So one is the fact that we think that the subversion of randomisation is probably less likely in cluster randomised trials, but it's more difficult to judge whether there is imbalance or not. We've got this new domain for this risk of bias. We've got a lot in there about this domain, which is about blinding. It's about, and particularly about blinding assessors. And one of the key things in cluster randomised trials, I think, is not to talk just about blinding. And actually, in general, it really upsets me when people talk about blinded trials or blinding in general, because actually what we really need to do is to say who is blinded to what and who is unblinded to what, and what effects might that have on the trial. And then a bit about missing outcome data, that can occur at the cluster level. You can have whole clusters missing as well as individuals. This is a table that is in the current draft paper on the risk of bias, which is on the website if you want to look at it. Okay, so going on to the ethics. So there's a really, really nice piece of work done by a major team, a large team mostly in Canada, looking at the ethics of cluster randomised trials. And we had the final consensus meeting in Ottawa, so it was called the Ottawa Statement. I'm not going to go through all these, but you can see there the kind of questions that this group has asked and answered in a really very thorough way in relation to cluster randomised trials. But the one that I want to pick up on is this question of who is the research subject. And this whole issue of are our practitioners research subjects within cluster randomised trials. And within the statement, a research subject is defined as an individual whose interests need protecting in a trial. And they have identified 4 things that make somebody a participant, and I've just underlined the top 2 here. An individual who undergoes a study intervention, so if an intervention is aimed directly at an individual, or an individual who is the target of an experimental manipulation of his or her environment. And I think in a lot of trials that would make, from an ethical point of view, that would mean that practitioners were also participants in cluster randomised trials. And so from an ethical point of view, one has to think about the interests that need protecting, their interests need protecting as well. So other contributions of primary care, which I won't go through in so much detail, but just very quickly, there's lots of data now. There's lots of trials, there's lots of data. And one of the really important things that people have done with this data is to look at patterns in intracluster correlation coefficients. One of the things you have to do if you're designing one of these trials is when you're calculating your sample size, you need an intracluster correlation coefficient in order to calculate your sample size. There's been a lot of work in primary care looking at what what sort of size of measure you need. So mostly they're around about 0.05, as I said before. And the other thing, the other contribution is this recognition that unlike some of the very early trials in infectious diseases, contamination between individuals is not the main reason for doing cluster randomised trials in primary care. There are other reasons. So this is just one example of piece of work looking at intercluster correlation coefficients plotted against prevalence for binary outcomes, and you'll see there is a relationship there that the nearer you get to a prevalence of 50%, the larger your ICCs tend to be. So where are we going to? And this is just really to sort of finish off. Where are we going? So I'm just going to put up a number of things which I think have changed since I started working on cluster randomised trials, and you may identify with some of these issues. So, whoops, let me go back. So at the top there, we've got a whole lot of stuff around design and intervention. In the middle there, we've got that issue of increasing regulation. And down the bottom, we've got some interesting things which raise statistical issues about how you design trials, about what you use to collect your data. And some of you will be familiar with the whole idea of embedding trials within other trials to look at methodological questions. So the major issue where these trials have been done is in relation to recruitment. How do we best recruit people? It's always an issue. In most of the trials that I've done, recruitment is an issue. How can we improve recruitment? One way is to do an embedded trial where you look at different methods of recruitment, but you do that rigorously. So you randomise people to different methods of recruitment. And these are two websites which look at those kind of designs, trials embedded within trials. I won't go through that one. This is an example of a protocol where they are actually using a cluster randomised trial to look at different methods of recruitment within a trial that itself is individually randomised. So, to finish off, where have we gone to from, say, OPERA to a trial I'm involved in at the moment called REACH? And I'm afraid I couldn't find out why it's called REACH. It's a programme on antenatal equity. It's improving access to and experience of antenatal care. And I would say this trial, it's actually 2 trials done in a programme grant, is even more complicated than OPERA was. It's complicated because we're using a lot of routine data. Anybody who thinks routine data makes everything easy has got another think coming. We're using lots of routine data, but not only routine data. So we've got the issues with the routine data and the issues with the data we're collecting from participants. We've got these 2 trials planned together. I'm also involved in a second programme like that where we're screening people and then we're treating people. So we've got 2 trials running at the same time. Could we manage to do embedded studies within these trials? I don't know. These things are very, very complicated. And then the whole issue of step wedge designs. So step wedge designs have come on the scene fairly recently. And so this is a diagram which shows a step wedge design down the side. Up the side there we've got A, B, C, D, which may be individual clusters or they may be groups of clusters. And we've got time along the bottom. And all the clusters start off in a white box in your control group, and then gradually they move across into being in the intervention group, but at different specified times. So it's a cluster randomised trial. Usually they're cluster randomised trials, but it's a slightly more complicated design. There's a paper in 2012. I won't go through this in detail. Paper in 2012 setting out the advantages of step wedge designs. In my view, most of the things that are stated advantages of step wedge design, you could do equally well in a cluster randomised trial. And so I would say steer clear of step wedge designs unless you absolutely need to do them. There are 2 instances where you might, and one is where you've got an intervention where it's policy driven, it's definitely going to be rolled out to all clusters over a period of time, and the other is that in some cases they can be more efficient. This is a little table of how many of these things. There aren't that many either methodological papers or empirical papers yet, but the number are growing. I think they're about the same stage as we were at with cluster randomised trials at the end of the last century. So some of the practical issues in these trials have not yet been looked at seriously. Where are we going? I don't know. These were just a few ideas. I've got a colleague, Richard Hooper, there at the top, who describes clinical trials like bicycles. He says it's all right if you know what a normal bicycle looks like, everybody accepts that's a bicycle. If you get some fancy thing, you want to do some clever design, and he's really into clever design, people don't like it because they don't think it looks like a bicycle. They don't think it looks like a clinical trial. So he's into let's be creative with design. There on the right, I wonder particularly within general practice whether we've got an opportunity to do more collaboration in these trials. For example, the trials on prescribing, trials on antibiotic stewardship. Do we need to get together and talk about these things if we're running them in different conditions, just to see if we can sort of maximise the information that we're getting out of trials? There at the bottom, I think we've got a massive issue with doing trials, and we've got the General Data Protection Regulation coming up soon. We've got a massive issue about risk, which has, we've all got to protect ourselves from every conceivable kind of risk. So this is just to kind of summarise where I think we've come from, where I think we're going to. My view is we are only going to go any further with this if we somehow get together both within trial teams and across trial teams and work together on this. So, and this is thank you to everybody and you for listening.
Okay, so it's time for a few questions. Anyone has any? Susan over there.
I'll shout at the beginning. Susan Smith from RCSI. Thank you very much, Sandra. It's such a pleasure to hear an expert in an area who really is so comfortable with the topic. Can I ask you a little bit about the idea of trying to measure contamination rather than cluster randomise? It seemed to be a bit of an issue a few years ago and it's gone kind of disappeared.
So I think it was David Torgerson raised this as an issue, didn't he?
Yeah.
And I think it goes back to the idea of why are we doing cluster randomised trials? And if contamination between individuals, like in the infectious disease trials, if that's your main issue, then maybe you can just measure contamination, do an individually randomised trial and measure your contamination. But like I was saying, most of the trials in primary care, at least, they're not done for that reason. So we've got to do the trial in a cluster randomised way for another reason, and therefore that whole idea of measuring contamination instead doesn't really arise in that case. So, I mean, I think it's to do with the types of interventions that we're doing. Yeah.
Andrew Murphy from Galway. Thanks again for an excellent presentation. It actually is a similar question.
Yeah.
I get a sense about contamination that there seems to be an increasing perception that maybe we're overestimating at times. Is there a set of rules that we can look at to say if these are all ticked, contamination isn't going to be a problem to guide us, or is that too simplistic a question?
If there are a set of rules, I don't know. But I think the other issue that you've got to think about is what's going to happen in the real world. And so actually, with a lot of these interventions, and you could conceivably think of some of these interventions running them as individually randomised trials. But in the real world, that's not the way it's going to be. You're going to have, your intervention is going to be put into a practice, and the whole practice is going to use it, or put into a nursing home, and the whole nursing home is going to use it. So there's something about behaviour and interaction between individuals, which means that if you try and do an individually randomised trial in a situation where your intervention will eventually be implemented at the cluster level, are you really in the real world? So I mean, I know I'm kind of, I'm arguing then for cluster randomised trials, and maybe that's because they're my bread and butter, but actually there's plenty around, so I needn't necessarily argue for it. But I do think you have to think carefully on other grounds. It's not just the contamination by itself, but it's about what are we really trying to do here if we want to do this for policymakers. So one of the issues in doing individually or cluster randomised trials is, for example, and I think David Torgerson was involved well, I know he was involved in this as well, is this whole issue around hip protectors in nursing homes. And what they found was that, looking at that you got very different results if you did an individually randomised trial and if you did a cluster randomised trial. And they may have different views of that, but my view of that would be, well, that's fairly obvious, because if you've got a cluster randomised trial, you've got the whole nursing home, where you've often got kind of turnover of staff and staff that are just there short term, but you've got the whole nursing home involved in the idea that you should give these people hip protectors. If you're just randomising people individually, then everybody's got to make sure, oh, is this a patient who should have hip protectors, who shouldn't have hip protectors? It becomes more complicated internally, and you haven't got that reinforcement from everybody around. So.
Sandra, Tom Fahey from RCS.
Oh, you're next door, yeah.
Sorry, Mr. Andrew. Can I ask about the ethical issues in relation to trials? Because, and your example of hip protectors is quite an interesting one. I did a few randomised trials when I was in the UK, and we did get individual patient consent at the time. And I made a bit of I don't know whether I made a fool of myself. I was a chair of a trial steering committee maybe 2 or 3 years ago, which is a cluster trial in the UK, and I was assuming that participants would be giving individual patient consent, and they aren't. So I had to get up to speed about how things had changed. But if you're looking at some of the things for the future, is talking about regulation, for instance, but your hip protector example is a good example. If my relative, or indeed I, in a few years' time, maybe in need of a hip protector, I think I should be consented or asked about being in a cluster for that kind of intervention, because it's a safety and quality issue, and I want to know the risks and benefits of that intervention. So it's that kind of ethical question. I mean, how can we as researchers or people recruiting people in clinical situations provide that consent, putting up information leaflets, and is that sufficient? And is it context specific in terms of the examples in terms of regulation?
So I think it's very, very context specific. So I'll give you a couple of examples, but I think you're absolutely right that and the whole issue is about risk. So in something where there is a kind of personal safety risk or benefit, particularly in that kind of sort of example that you gave, where you may know what the benefits are anyway, but you're just trying to implement them. So in those kind of cases, there may be a strong driver for individual patient consent. In other cases, you get the driver the other way, and I think you have to do it on a case-by-case basis. So, for example, the IRIS trial, which is probably the most influential cluster randomised trial that I've been involved in, was the one with Jean Fazer looking at improving identification and referral for domestic violence. It's had a massive effect. But in there, because you need to balance the two things, and I think that's the issue here. You need to balance the ethics and the science. So we'd already done a pilot where we found that trying to get individual consent and trying to measure outcomes on patients was A, impossible, and B, might lead to some kind of bias. So actually we wanted then to implement the intervention in clusters or not in the control group, and then measure the outcomes using routine data. We felt that was going to cause less bias in the trial. And that just would have been impossible to get individual consent to that. So we measured outcomes on thousands and thousands of participants. And I'm calling them participants, though they didn't know they were participants, but still from an ethical point of view they were. So in that case, I think there's a very strong scientific driver not to go for consent, and I think it's the balance between those two, and that's why in that one of those slides of the mouse with the helmet on, I think we need the science and the ethics needs to talk to each other, and in individual trials, but also more generally, because otherwise you get, in my view, some in Europe, and I don't think it's happened here so much, but in Europe there are some balmy legal and ethical kind of regulations which prevent you doing stuff because people haven't understood the science.
There's time for one very short question, and then I'm throwing somebody in the taxi.
Please don't be put off by the idea that it has to be short. I will keep my answer short.
Literally, I'm going to pick her up and throw her into the
So just sharing that space. So I'll probably finish on this June's question because some of this goes over my head, but it was a great presentation. Tom Barry's my name and I'm from UCD. One thing you didn't touch on was the number of actual clusters and where that fits in with the methodology, because I guess from where I'm coming from, it's probably out of convenience a lot of the time that someone might move towards the cluster design.
So it's actually that is really, really important. So those trials that I talked about, I think there's sort of there was the small one. I would say that was a small one, the one done in 1973 with only 14 clusters. Most of the ones I've been involved in, 40, 50. The Opera trial had 78 clusters. So you need those kind of numbers to do the kind of analysis that is ideal in these sorts of trials. But you also you have a problem with having a very small number of clusters, because sometimes you just simply can't get enough power with a small number of clusters, and it doesn't make any difference if you have thousands and thousands of people within each cluster. You just can't get enough power. So you do need a sufficient number of clusters. Sometimes, so we're doing one at the moment which has got about 10 or something. It's very, very small, and then we're using a match design. You have to use a slightly different design. You can do it with that number of clusters, but I would always recommend, if you can go for a larger number of clusters, then that is better.
Okay, that's it. Thanks a lot.